Hello and welcome to my Road to Yamane technique chapter number 2. In this part I will show you what instrument that I use for training and give you some tips about the technique itself from my point of view, hopefully. First, you have to mark 6 critical points on the sclera for a scleral tunnel creation, and if you will follow them, you will avoid tilting of the lens after surgery is completed. So 6 points, 2.5 mm apart each. Then I create 3.0 mm clear corner incision, followed by 2 paracentesis. Try to create good angle of approach during side pore creation. Be sure to avoid any bubbles during viscoelastic injection into the anterior chamber. They can negatively impact on the visualization. I bend my TSK thin wall needle bevel up in approximately 85 degrees angle. Then I make a scleral tunnel and eventually enter the anterior chamber. During implantation, I use Alcon MN60 AC with the PMMA haptics IOL. Be sure you have placed an IOL safely into the cartridge. After, I go into the anterior chamber through the side pore incision to grab the leading haptics and insert it into the lumen of the needle. Notice how annoying can be viscoelastic bubbles. Also, I don't use AC maintainer for obvious reason here. You can see that leading haptic insertion is really not that hard at all. It goes smoothly into the lumen of the needle. Then I bend my second needle at approximately the same angle. Sometimes tunnel creation is not that easy, as it seems, due to the stiffness of the sclera, especially in patients with the long-lasting glaucoma disease. In this case, I push the trailing haptics through the main incision. And I want you to notice that it's already bent while entering the anterior chamber. So normally I would use the side port incision to insert the trailing haptics, but in this case I use slightly different approach. You can now see how fragile the PMMA haptic is. It bends really easy. You see, boom, and it's already bent. So I recommend to use CT Lucia from Carl Zeiss with PVDF haptics. But this is what I like about training. You can always go through the different scenarios. For example, here I just cut the end of the trailing haptics and tried one more time to insert it into the lumen of the needle. Obviously, due to the angle and because I do it with my left hand, it is not going as smooth as with the leading haptics. But eventually I've managed to insert it into the lumen of the needle and basically get it out from the eye. Well, I tell you honestly, in real case, this small end will get you in trouble. You won't simply see it due to the chemosis of the conjunctiva. And the last thing you have to do is to cauterise the end of the haptics with the low temperature cautery. And remember to have intraocular IOL explantation instruments. I use Snyder or Osher from Goider. They are really helpful during training and the real case.